Hi, my name is Sonia Horner, and I am the Chief Commercialization Officer for Onegevity. I have the distinct pleasure of introducing and interviewing today Dr. Bob Rountree. He needs no introduction, but I will do him the courtesy of an introduction anyway. He is an IFM faculty member, a practicing physician for over 38 years, a dear friend to many in the industry, and also a Linus Pauling Award winner. Dr. Rountree, thank you so much for joining us today.
My pleasure, Sonia.
We wanted to spend a little bit of time with you and talk a bit about the Onegevity Gutbio test and what your thoughts are about what's being offered by Onegevity and how you use it in your practice.
You bet. Be happy to talk about it. I can give you some context, which is that I've been doing gut microbiome testing for many, many years now using various other labs. And I've used most of the commercial labs that are in business today. So I have some experience with what's out there and what's available. And I do want to kind of make a point very early on that this new Onegevity test is really revolutionary because of its accuracy. The test, what can I say? The early versions of these tests have been somewhat crude. And so they, in essence, they're using something called the 16S sequencing. They're looking at the 16S ribosomal gene, which is pretty good in its day. It was a very good start. But we've since learned that there are a lot of limitations. And the problem is, and this is going to shake some people up, but that you can do repeat testing on the same sample and get different results when you're doing 16S sequencing.
And when you're referencing the 16S sequencing, are you referencing, and you don't need to bring up any names, but the players in the market that are currently marketing directly to consumers online?
With the exception of one lab that does RNA transcriptomic testing, the rest of them are doing 16S. Now, some of the newer published studies that are coming out of universities are using the same technology that's in the Onegevity test, which is the metagenomics testing. Metagenomics testing basically looks at all DNA in the sample. And that's going to include human DNA.
Okay.
Right. So I can't even stress how sophisticated this testing is. It's just on a whole different level. The other thing with typical 16S sequencing, or some labs use PCR testing, is that you only find what you're looking for. So you do a probe to see if there's a certain microorganism.
Okay.
Right? If you're not looking for that microorganism, you won't be able to find it. Whereas the metagenomic sequencing that's done in the Onegevity test is agnostic. It just says we just want to know everything that's there. And so the report that you get, it provides what's called a community breakdown that's pages and pages of bacteria, fungi, parasites. It's really, really, really comprehensive.
But at the same time, do you also feel that it's consolidated in some ways? So for patients, when they receive the results and they're reviewing them with their physician, that they are able to interpret the information?
Yeah, there's both the simple version and the complex version. So the simple version breaks it down and says, first of all, did we find any pathogens?
Right.
Which I think is useful. So this is not a diagnostic test for Clostridium difficile, for example, right? But if there's Clostridium difficile in the sample, it will find it because it's that accurate. Why isn't that diagnostic? Because certain people will have Clostridium difficile in their gut and it's not causing any symptoms. Right? So what I'm saying is you do the pathogen analysis, and then if it's there and you have any reason to be concerned that that's causing problems, then you would do a follow-up test, which is to look at the C. diff toxin.
So there's
right. So this is your initial screen.
Right.
I'm
Okay.
sorry to interrupt. Yeah.
No, excuse me. I'm sorry. So you find that the test is it's obviously communicated in a form that works with a patient, but it provides comprehensive information that a physician needs in order to, or provider needs in order to design recommendations for the patient.
Right. So a patient can understand it, and the analogy that I've used when I've talked to practitioners about this test is like, you can get in a Tesla and drive it off the lot without knowing anything about electronics.
Hmm.
Right? You push this button, you put it in drive and you go. And this test actually has that level of reporting, where it will say, number one, we did or did not find any organisms that could cause serious problems, pathogenic organisms. Then it says, this is how you compare to other individuals. Are you more or less diverse than the general population? Everybody can understand that, right? You're 20% of the population is more diverse than you, 80% is less diverse than you, so that's understandable. Then we have a list of organisms that could cause inflammation. That's very useful. So, if a person was at risk of inflammatory bowel disease or cancer, they may have higher levels of the bacteria that can cause inflammation. So again, very straightforward. Then a list of organisms that could cause constipation and a list of organisms that could cause diarrhea. So that's the user interface, as it were, of what this test looks like. Right? How do you compare to other people? Do you have any bad bugs? Anything that needs follow-up testing, all that's there. But then I mentioned this community breakdown. That's a downloadable part of the report. So that's the person that says, well, I want to know how this Tesla runs.
Right.
Let's lift up the hood and let's take a peek at the electronics. And I want an explanation of those electronics. Some people don't want that or don't need that. They just want to know, what are the general findings and what do you recommend? But other people, and I've certainly talked to doctors that have been doing testing like I have been for years, they're ready for that extra data. Mm-hmm. And they know what to look for. And an example I can give you is that we know there's certain organisms that are more likely to ferment food and cause gas and bloating. And that gas and bloating can be a major part of symptoms of irritable bowel syndrome. Right? So if you know what those organisms are, then you can do a quick search in this downloadable report, and you can immediately find out whether those organisms are there, and if they're there, in what level of abundance they're there. Or if a person says to me, like a patient I had the other day, well, will this test tell me if I've got yeast? Do I have Candida albicans or other organisms? Absolutely. If they've got fungi, this will show up, because this is looking for the DNA of the yeast. So it's all in there, but that part of the report is really designed for the physicians that want to take, or the healthcare practitioners that want to take the next level.
So you just mentioned one of your patients. I think it would be really helpful for us to hear how you would walk through a first visit with a patient that you think would be a good candidate for this type of test.
Okay. Well, a typical patient that's going to benefit from this is somebody who's had chronic GI problems. Say they've had gas and bloating for years, or they have chronic constipation or constipation and alternating with diarrhea, classic irritable bowel syndrome patient. Or maybe it's somebody that you're a little worried that they could have colitis, inflammatory bowel disease. Right, but they're not having full-blown symptoms. Maybe they're having some pain, they're having some diarrhea, and you're not sure if they've had bleeding or not. Well, the first thing you're going to do is your due diligence as a physician, right? There's standard blood tests that I would do on anybody, especially if they've had new onset of symptoms, or somebody that I'm worried about inflammatory bowel disease. I'm going to do a complete blood count, make sure they're not anemic, so that I'm not worried about hidden bleeding. I might do an iron level to make sure they're not iron deficient. Men shouldn't be iron deficient. So if you find that in a male patient, that's going to make you suspicious of blood loss. I do a complete blood count. I would do a C-reactive protein to look for inflammation. So I would do these basic tests on most everybody. And again, if there's any concern, if there's weight loss, for example, the concern that this could be some chronic disease, then I'm going to do a fecal occult blood test. And there's a number of really good ones. The fecal immunochemical test is a really good one. So again, I want to make sure that I've ruled out disease. So I'm not, telling somebody you have bacterial overgrowth and there's something more serious going on.
Sure.
So I started by doing, I'm a doctor, that's what I do. So, you rule out disease. But mainstream doctors, a lot of times they feel like they've done their job, when they've ruled out disease. You don't have disease, you have irritable bowel syndrome, just learn to live with it.
Here's your label, right.
Here's your label, we've got the label, and we're done.
Right.
What I'm going to do with a patient like that is collect data about their diet. It's surprising to me how often people don't really understand the relationship between their food and their symptoms.
Right.
They kind of have a feeling something gives me gas or something gives me diarrhea, or there's something about how I'm eating that makes me constipated, but they haven't really thought it through.
And how do you collect that information?
Well, the simplest thing to do is a basic diet diary, just a piece of paper that says this is what I ate and these are my symptoms. And the Institute for Functional Medicine has a really, really good handout for that. So that's for somebody who doesn't want to take any extra steps. They just want to do something basic. Or they could use an iPhone app, like there's one called My Symptoms that you and I have talked about in the past. It's really elegant.
It is.
Really, really elegant, that gets down to the nitty gritty. It's very, very granular. Mm-hmm. So for a person that wants to go beyond a basic food diary, then that's the ideal direction to go in. Now, occasionally I'll have somebody that comes in that's just got a classic case of what appears to be small intestinal bacterial or microbial overgrowth, with gas and bloating that occurs, say, within 1 to 2 hours after they eat. And that person, I might get a little more specific with diet and say, I want you to be on a low FODMAP diet, fermentable carbohydrates that could cause gas. So I might even go, to that level with them on the first visit if they have classic symptoms. Okay. And there is an app that the Monash University has that I think is really great. It costs about $8. And I've gotten rants and raves from patients about that. Then I'm going to probably start some simple supplements. I'm going to use probiotics probably from the get-go. And there's some really elegant algorithms out there for deciding which probiotic. On the Thorne website, for example, there's a nice algorithm that you can walk through. Do you have these symptoms, those symptoms? And it will help you determine which probiotic to use out of the Thorne range of products. So I almost always put people on a probiotic. I may put them on a digestive enzyme. If it sounds like they're not digesting their food, I may put them on a fiber supplement, or I might even put them on an anti-inflammatory like Enteramin. So I'm going to do some really basic interventions. But again, if somebody's had chronic symptoms, at some point I want to know about their microbiome, right? And either at the first or maybe the second visit, that's when I'd recommend something like the Onegevity Gutbio test. Okay. It's just going to take a month or so to get the results back. So I like to get started on the diet, get started on some basic supplements, and then when they come back for their follow-up visit, we can have these results in hand and we can say, look, this is what we found.
And do you find too, Bob, that when patients see kind of what the test tells them and then you make a recommendation, do you think that education with the recommendation kind of builds acceptance of your recommendations? I mean, well,
it's one thing if you tell somebody, I think your gut microbiome is involved in your symptoms, and they go, yeah, but that's a very nebulous concept.
Right.
But if you can say, I think that you are fermenting your food excessively, and there's certain microorganisms that can do that. Here's one, Ruminococcus navis, that could do that. And hey, look, and this is an actual patient. I can pull out his microbiome results and go, look, you've got an overabundance of that particular bacteria, and we need to do something about it. We need to starve it out, maybe a low FODMAP diet, or use something like berberine, which is a kind of a broad spectrum antimicrobial, to lower the levels of that particular organism. So there's no question that this helps with compliance. That's really the big issue here. You could do all the same interventions without the information, but it's analogous to measuring cholesterol in someone who is concerned about their risk of heart disease.
Right.
You can say, oh, I think you should eat thus and so a diet. We don't need to check your cholesterol. But if you do a lipid panel and their LDL is off the chart, you can say, here is something that's going to give us feedback about our intervention.
And the fortunate thing is that as the patient is working with you and following the recommendations, their symptoms are hopefully regressing at this point. So it feels like that, over this 2-month period of time between when the initial test is collected, within 4 to 6 weeks, the test results are delivered. You've got a patient within a 2-month period of time who has now made lifestyle modifications. They've tracked, the dietary modifications that they've made. So they're starting to understand their triggers a little bit more.
Yes.
After that 2-month period of time and you're kind of inching your way into the 3rd month, what do you see happening with the physician and the provider in that relationship with the patient? And do you find that it's necessary to have another Gutbio test drawn at that point? What would your recommendation be?
Well, certainly an ideal scenario is to be able to show the patient that something changed.
Right.
Right? Or that it didn't change.
Mm-hmm.
Let's say the test came back and it showed that they have high levels of inflammatory organisms.
Right.
And so you put them on Mariva, curcumin phytosome, right? And there may be other things like I said, I mentioned the Enteramin product, which is Mariva and Boswellia, aloe, partially hydrolyzed guar gum, glutamine. So there are things that we can do that are really specific for these inflammatory organisms. But you'd like to see that you're making a dent.
Absolutely.
Right? And the reason, so why don't you just assume that? Because a lot of times these microorganisms get sucked in. Mm-hmm. Sometimes a person's had that microbiome for years, maybe their whole life. And I love it when you do some simple interventions. You put them on probiotics and digestive enzymes, and it dramatically improves. But sometimes it doesn't. So you need to know, well, are there some hardcore organisms that we're not getting at? Do we need to double up on our therapy? Do we need to be more aggressive? So that follow-up test can actually be very useful, to tell what direction you're going in.
And it really kind of solidifies, the patient is improving, the physician is also, and the provider is also seeing those results improve. So as they kind of exit the program, so to speak, they've got life skills that they can use, and it's been confirmed for them that they are in fact have fewer symptoms and that their microbiome has improved.
Absolutely.
Heaven forbid in the future, years from now, should they need to revisit this information, with you, at least we have it, right? So we know with that second test kind of how much they improved, and can always serve as a good reminder of the work that they kind of followed during this 3-month period of time. Is there anything else that you wanted to share with folks?
Just that I mentioned this before, but I do think this is a revolutionary advance in gut microbiome testing. It is designed to be readily accessible and at the same time incredibly comprehensive. And what I think is exciting about it is that now that we've got this level of detail available to practitioners, there's going to be a lot of learning involved in terms of what are the ideal interventions for these particular microbial signatures.
So there's definitely more to come.
There's more to come, a lot more to come.
Well, thank you for sharing your expertise.
My pleasure.